It's a 61-year-old female. She has an on-stem past week, Fausto. She's asymptomatic since then. She has a comorbidity. She has a hypertension, and she's a current smoker. And she has laboratory tests. There's normal renal function.
Okay.
She has normal. She did echo. She has a preserved LV function with a little hypokinesia inferior wall and infralateral wall.
Okay.
So we did an angel and the cath lab.
So a small circ.
Yes.
The most important thing that I see here, beside the lesion, beyond the lesion, it's the small circ.
Yes.
I can realize the right is going to be a huge right.
Yes.
Okay.
The lady, I think she's moderate to severe lesions on the mid portion and a little bit on the distal portion. From the right side, on the right. Okay, so we see a severe lesion.
And also a huge calcification.
Yes.
In the proximal part of the right.
Yeah, proximal and a little bit less
distal too.
In the distal too.
4 lesions, main lesions in the right.
Yes.
Okay, what is the strategy for today?
The strategy is to go for the Cropper lesion. That's the RCA.
Sometimes when you have a very complex case with tortuosity and also calcification, and the small lady, smoker, the radial artery usually is not so good.
Not good.
So we choose 7 French guide, femoral artery, and what kind of guiding catheter would you choose for this case? Would you use a JL or an Amplatz?
A good support. And
Good support. Amplatz. So we have the superior ostium. The backup usually is not so good in this situation. Second, we have 4 lesions at least. 4 lesions. Actually, we have 5 because we have a lesion in that marginal branch.
Yes.
I saw that picture that you showed nicely. So, and we have calcified, strong calcification of this artery.
Tortuosity too.
And tortuosity too. Okay, good. So we have all the factors to get in successful. So this is a challenging case to do this in this lab. Rodolfo, what kind of guide wire did you choose?
We try, the first one is a workhorse, it's a BMW.
BMW?
So we just filmed the repressing through the lesion.
Okay.
So although it's a tight and really lesion on the proximal to the mid third portion, we did good guidance from the guide wire. So
okay, with the guide wire.
Yes, we didn't have any trouble.
So that's what you have done so far. So you tried to get the BMW there.
Yeah.
Yes.
It was easily.
Easily. As we can see in the angel, we are trying to pass a non-compliant balloon
225.
225. 225.
225.
Okay, 225 balloon, non-compliant balloon.
Yes.
Did you get successful?
No.
No. Why the balloon did not cross the lesion? Because of the severity, or because of the calcification, or because of the tortuosity? You have 3 options.
Perhaps the 3.
The 3. Okay, 3 of them. So
we thought about using a atherectomy. Rotational.
So you need an additional preparation.
Yes.
The balloon could not make the job.
Yeah. So
you took the BMW wire out and you brought the rotor wire.
Yes. So we can exchange in a way that's secure.
Okay.
And how can I say the?
Can you show? Okay. Now we are seeing your hands.
Yes.
You are bringing back the Mamba catheter.
Yes. And leaving the
rotor wire
distally.
Okay.
Yes.
Being so concentrate now.
Yes. Yes.
And you have the rotor wire. This is a challenging case. So when you have a right coronary artery with tortuosity, calcification, and severe lesion in superior ostium, there are 4 factors that can make your procedure very hard. Now,
just testing the blur.
Devagar, Patrícia.
Good. Okay. 160.
Okay.
The device was tested. Everything is fine. The patient is fine with blood pressure and also heart rate. In the video, now he's bringing. Louis is just holding the wire with pushing the button here, as you can see here in his hand. Rodolfo is bringing the bore. Hopefully we can get cross of that tortuosity. He's gonna get the guiding catheter inside of the artery right now. I'm gonna relate the case now. Rodolfo is bringing. So So this is
Okay.
Sterzer. Simon Sterzer was used to do this to across the bore. So we just with a small acceleration of the system, small and short. Now we have the bore pretty close to the curve, and he's starting acting this, as you can see here. Did cross easily. He's going a little bit distal to the second lesion. Okay.
Okay.
The blood flow is okay, as you can see here. Now we are running about 140,000 with a nice demonstration of how to do an ablation of this artery, and quite easily. Let's see the flow, distal flow.
Okay.
It's fine. It's great. Now you are going to bring it back the bore. And Louis is going to push in the button under, so in bringing it back.
Right.
Now we are 60,000 rotation, as you can see here, with the rotation. Can you see here the rotation device?
Wow.
So we are going to keep just one bore, 1.5, and now he's going to exchange the wire again, the Mamba catheter, the micro catheter. If you look at the Louis' hand, Louis is preparing the Mamba
Pega BHW.
and change the wire, the rotor wire. We cannot forget the rotor wire is 0.009. We are going to change now the guide wire to a 0.014. Now we are looking at the end. Louis is holding the wire. Rodolfo is advanced the Mamba, the microcatheter by Boston Scientific. That's a very good microcatheter. Take the rotor wire out
BHW.
and bring an extra support guide wire.
BHW.
Now we have the distal part there. If you look at the Rodolfo hands, he's advanced the wire, the guide wire. It's very important, so smooth. We don't want to get any perforation in the distal vessel. And now Louis is going to hold the wire and bringing back the Mamba, the microcatheter out, as you can appreciate in the screen. Very nicely exchanging wire. And also a nice demonstration. Now we have the 2.5 balloon there. Now it's very important to see the expansion, because if we did not get a perfect expansion, even with high pressure, maybe you need to change the strategy.
Yes.
Let's see, 2.5 balloon. Let's see.
High pressure.
Great. Now it's the balloon is
25.
full.
25.
25 atmosphere.
Deflate.
Balloon is full expanded. How many seconds? Only 10 seconds?
10 seconds.
So you're faster than anyone that I
Right.
I have worked too. Now look at the heart rate is okay. Blood pressure is also okay. Again, as you can see, the 2.5 balloon with the 25 atmosphere.
Okay.
High pressure balloon.
28.
Okay.
Deflate.
Do you think it's fully expanded in the proximal?
But
We don't need a 3.0 to a better preparation of the artery?
we need a bigger balloon.
A bigger
3.5,
balloon.
Yeah.
3.0. 3.0 or 3.5? You are going to do
3.5.
that, or you're going to place a
One-
stent first?
One by one relation.
Okay, one by one. Whoops. See, that's very important.
Yes.
That's so it was quite easily with the 2.5. We went from 2.5 to 4.0. Maybe it's better to bring a 3.0 now, Rodolfo.
We have a Godzilla.
Guidezilla again?
Again?
Okay, let's try the Guidezilla.
Okay, thank you.
That's a good option. So we are going to bring the 4.0 through the Guidezilla.
Okay.
Yes.
Okay, let's see the rule of Guidezilla.
Test.
So what's the pressure you use here, Louis?
4 atmosphere. 4.
4 atmospheres.
Right.
So
Yes.
we use the 4 atmosphere,
Now we're going up to 6 now.
Right.
6 atmosphere.
10.
Great.
8 to
10.
10 here.
10, it's almost
Yes,
fully
15.
open.
Yeah, yeah.
That's a good lesion preparation.
Deflate.
The balloon is completely open, fully open. We went up to 10.
10 and distally up
Okay.
to
Okay.
40.
Now Rodolfo is working the mother and child technique. He's going to be in back the Guidezilla. See,
Yes.
the guiding cat is a little bit intubated in the right coronary artery, but the Godzilla is back and he's keeping the balloon exactly on the lesion.
Here.
Okay.
14
Now,
atmosphere here.
14
Fausto.
atmospheres, the balloon is fully open. That's important. So after you have the balloon fully open, we don't think we need to use shockwave. Is that correct? That's
think
important.
so.
Yes.
That's an important teaching point. Let's see if the
Test.
balloon. Good distal flow. And let's see.
It's like a simulation for the
He's
stent.
bringing with his left hand to get a better support with the guiding catheter and pulling the balloon, the 4O balloon. So, see, it's a little bit hard. Sometimes the stent didn't go through if you don't have a Godzilla there. That's my opinion. Let's see with the Godzilla. Again, he's bringing back the Godzilla to make the test, to put the Godzilla close to the lesion. See, the mother and child now, he's pretty close. Good. The Godzilla can get across everything and you can bring the balloon back, keep the Godzilla there. How about the distal flow with the Godzilla? Do you think it's good?
It's good.
Work a little bit fast now with the hands and bring a 4/35 coronary stent in the distal lesion and to give some flow to this coronary artery. So the distal flow is a little bit down. Now the stent is there. He's going to bring him back the Godzilla. Can you see that?
Yeah.
Bringing back the Godzilla. The stent is in place.
Test.
We're going to test to have the better position that we have. Yes, okay.
Okay.
Okay, perfect.
Okay,
Stop.
inflate. We are going to get all the lesion there. So the stent is a 4/35. We are 6 atmosphere. We need to be careful to the distal.
Okay.
No, not with high pressure
Inflate.
at this point.
Deflate
What kind of stent we are using here?
or zero?
Or Ciro by Biotronic. Now, Rodolfo, if you look at the Rodolfo hands, he's bringing the 4/40, as you can see here, through the Godzilla, the mother and child technique again. That's very helpful. See, you can see the stents over there. So you're going to try to take that lesion in the proximal part. He's so carefully bringing back the guiding catheter with his left hand. As you can see, if you look at if you can show the left hand, Rodolfo left hand,
Sorry.
pulling back the stent with the right and control the guiding catheter with the left. And now Louis is inflate the balloon, the stent, with a 4/40 or Ciro that's made by Biotronic. It's sirolimus, yes? Sirolimus. Sirolimus drug-eluting stent with a biocompatible polymer. Is that correct?
Yeah,
Very thin. It's about 60.
yes.
Okay, 60 micro.
Test.
Okay,
Looks
that's
really
a
good.
very good flow. Now with both stents, we still need to work on the stents, man, because we just deployed at 10 atmosphere, the maximum.
Yeah.
So now we are taking a 4/20. No,
Yeah, the same.
or the same balloon you did the pre-dilatation.
Yes.
Okay, good.
Inflate
Okay,
the balloon.
okay.
Inside the catheter.
Inside the catheter,
10 atmospheres. Okay.
Just to get a good deflation, because the balloon was used before
Yes.
to do the pre-dilation. So if you inflate the balloon inside the guiding catheter, deflate pretty fast and bring the balloon. Didn't go through?
No, the Godzilla.
What happened with the Godzilla?
Because the balloon is huge.
You need to take another
Yes,
balloon.
We're going to use a new one here.
A new one. Okay.
A4.
Now we have also, if you look at the hands, Rodolfo hands here, he's advanced the 4/0 balloon, keeping the wire, 4/20. And now let's see the mother and child there, if you can go with a new balloon. See, now he's getting that. Yes, it was quite easily. Great demonstration. Now you went up to 25, 20 atmospheres with the 4/0 balloon.
Yes, distally here, false.
So we have about
25.
75 millimeter coronary stent. We placed the first one with a 35 millimeter long, and the second one was 40 millimeter long. Now we have 75, and Louis is going up to 24, 25 atmospheres. Can we show the balloon expansion in the next time, please?
Here,
The blood
Fausto.
pressure is fine, the right heart is fine, and now we are 25 again atmospheres. The balloon is fully expanded. Are you satisfied with this balloon?
Yeah.
So we are comparing the size, balloon size, with the artery size.
So we do a ratio 1 by 1 to
1 by
1.
1 to 1, 1 to 1. Increase this ratio up to 1.1, 1.2.
Balão.
There is a risk to perforation in a patient like this.
So good.
So good. How about this though?
Yes,
There is some tortuosity,
yeah,
some
perhaps we have a
effect.
from the guide wire here.
Yeah, yeah.
While preparing the IVOS,
The IVOS, we're going to do a
post-dilation.
4-5 and we're going to finish with the IVOS.
Yeah.
Now Rodolfo is bringing the 4.5. Can you, okay, may you have the angel now, the big screen? Okay, good. We are okay. You can keep the IVOS there because we're going to use IVOS later on. This is a 4.5. It's inside of the stent.
Yes. Not
Are you
totally,
sure?
Not
Are you
totally,
sure?
Not totally.
Maybe you need the mother and child
Yes, he's already using it.
to give a better support.
So that shows how complex this lesion here is.
Yes.
Although we treated with a stent, it's still tortuosity.
Yes. Let's see.
Huge.
Rodolfo now have a better guide support with the mother and child, the Godzilla.
Yeah.
And now he's bringing the balloon there, bringing back the mother and child, pulling back. Yes.
Pull back the balloon.
Good technique. Now you're going to inflate over there or just in the proximal?
Okay.
Inflate, but not very high now.
Yeah.
What the pressure
5.
is?
I'm using
This
here
is a 4-5 balloon.
8 atmosphere here.
Okay.
Okay.
A little bit
Little
more.
4-5.
10,
10, up
10.
to 10 here.
11. 13.
Okay.
That's okay. Deflate.
Great technique. We went up to 11 atmosphere.
11 atmosphere.
11 with a 4-5 balloon. Rodolfo pulling back the balloon. Now he's inflating. Can you see the angel?
Yeah.
What did you do here? You inflate the balloon?
It's difficult to.
Okay, you had some
Trouble to take
trouble
off the
to take off.
Okay.
Now you are going to bring the balloon.
here. Oh,
Okay.
just
Okay.
and I think
Okay,
now
looks
it's got a
okay.
little bit better.
Better. How about the proximal part?
The proximal, it's perfect.
Looks okay.
And distal, some nitro, it's okay.
Here,
Distal,
Faust. Here.
Okay.
distal,
The proximal I got.
and
a
the
little bit
distal
better.
too.
So are you going to inflate the 4-5 proximal?
No.
No. Do you think okay?
I think okay.
We are distal now to the lesion, distal part. Distal transition looks good. There is no dissection. This is a large vessel, 1, 2, 3, 4 vessel, 4.5 vessel. The stent is well expanded,
Yeah.
at least at 270 degrees. The stent is well expanded, well opposed. There is no plaque prolapse. It's a great result of IVOS at this point. It's a long run because we have a 75 millimeter coronary stent long. Now the vessel is larger, still with a huge shadow of calcium, almost 360 degrees. Now is the proximal part. There is some artifact in there, but the stent is well expanded at that point where Rodolfo overexpanded with a 4.5 balloon, as you can see here. Now we are proximal. Again, the stent strut is very thin with the Nobori, but there is no stent malposition in this long stent. Now we are the proximal part of the coronary artery, and now with the aorta.
Very good transition.
It's a very good transition, very good overlapping of the stents. And are you satisfied with the IVOS? Okay, good. Let's do a control engine. I'll leave you here to work a little bit more in the distal. If you have time, I'll come back here and we show what you work in the posterior branch, okay?
Okay.
And I'll be work with Ricardo live.
Okay.
Can you see the angel now?
Yeah.
Just to see?
Yeah.
Can you?
Right.
Okay.
Okay.
Great. Absolutely great. Absolutely great. Thank you very much for this nice demonstration. Balloon, guide support, tortuous vessel, calcified, rotablator, oversized balloon, 4.5 and IVOS.
Yeah.
See you later.
Bye-bye.
Thank you.